All right. Maybe just 10.
Or 3. Yeah. Whatever works.
All right. Well, those of you who are on early enough to hear the Casey's Pizza banter, it's a regional chain that we're just discussing how much we love. So sorry you had to hear that. But we did have a couple participants who joined in, so I'm sure there's some of you that are in on this. With that, though, my name is Steve Kershke. I have Don Terry in studio as usual.
Good
Don,
morning.
welcome. But we have a couple guests that are typically remote. Laura Brown, welcome in from Denver.
Good morning.
And Dr. Jeff Snell, welcome in from Virginia.
Good to be back in the shop.
Good to have you. Good to have you here. So with that, we are going to be talking about concussion today. This is round 2. Jeff and I have had a really more formal run through in this presentation. Lucky for you all, we're going to probably make a ton of changes, and we walked in this morning and we made 0. So we're apparently going to do that on the fly. But we hope that you enjoy this topic. It's pretty top of mind for us for various reasons, which we'll talk a little bit about. Before we jump into that and I turn it over to Dr. Snell, make sure my screen. Quick rundown of QLI. Those of you who are familiar with QLI, welcome back and welcome to our webinar. If you're new to QLI, we're a post-acute rehab provider. We also have an outpatient tele-rehab program that is, it's no longer new. It's been around a little over 6 years, but it's starting to pick up steam. But we specialize in traumatic brain injury, spinal cord injury, chronic pain, limb loss, and stroke. So pretty much anything complex and mostly related to neuro is in our wheelhouse. And so you see on the right-hand side of the screen a picture of our campus. We sit on about 60 acres of land in this kind of the eastern part of Omaha. So we're a center of excellence model, and we have pretty large campus, more campus style, less of a hospital setting. So if you're ever in the area or you have a desire to come here, please let us know. We'd love to give you a tour. Some housekeeping. Please use the Q&A. Those of you who are regulars, you know that we monitor it throughout the presentation. We'll either answer it right as it comes in or we'll save it to the end. Typically, we have time for questions at the end, so we'll do a little bit of both between Don and myself and Laura. We'll monitor that. We know that you want your CEUs. As a reminder, CEUs are for CCMC only. We just ask that you stay for the majority of the presentation. We will have one poll question at the very end. There's a dedicated slide for that. So if you don't see a slide, you haven't missed the question, but keep an eye out for that. We just ask that you answer that. And then once you click Leave Webinar, it should kick you over to a separate tab in your browser where you will fill out the JOT form, hit submit, and you will automatically get your CEU certificate as well as the slides. They will come all in one document automatically after that. There are some occasions where that doesn't happen. Just email us. We'll get you taken care of. All right. With that, Jeff, are you in a spot ready to go?
Oh, yeah. I was just setting up a timer on my phone, but didn't quite get it done. So that
if
means I
you're-
just get to talk as long as
I didn't know if
right?
you were texting Matthew or what you got going on.
No, he hadn't called, but he
teasing.
usually does. Yeah.
All right. Let's get started.
All right. So the classification of traumatic brain injury is done in the immediate post-injury presentation, or the observable and measurable aspects of consciousness, cognitive, sensory motor functioning upon restoration of consciousness in those instances where loss of consciousness is present. In general, a more severe injury is associated with more severe levels of acute deficit and a lengthier duration of recovery. And with that also comes a greater likelihood of ongoing significant changes to one's cognitive, emotional, or physical functioning. But again, that is in most cases and not all. The classification of severity of brain injury does not reflect lifelong measures of symptom presence or absence, just the immediate post-injury status. So one can have a very severe brain injury from which there's a relatively complete recovery, apparently, near baseline recovery, although in those instances, some subtle deficits may remain. Or you can have a mild brain injury from which there are lifelong and significant changes to one's functional abilities. Again, that is atypical, but in both of those cases, that can occur. If you look at large population studies, typically a more severe injury is associated with more severe symptoms, more lifelong presentation, but that is not the case in all traumatic brain injury is not a homogeneous diagnosis. It is all over the board. It highlights that TBI is not a unitary construct. It depends on exactly what aspects of the brain are affected, how much neurological disruption is present in that injury, what global aspects of functioning may be impacted, and what is the interaction of all those aspects of brain functioning and the life demands of that individual. Basically, there are a host of a lot of other biopsychosocial issues that have to be considered, and the short version of that is it's complicated. So what you're looking at here is the Glasgow Coma Scale. That is one of the quick measures that is utilized to look at severity of a neurological insult. Your score on this is going to be somewhere between 3 and 15 possible points. If you look at across the bottom of that scale, that would represent coma, no eye opening, no verbalization, no motor response. As you get further up on the scale, each of us right now typically would rank 15 points. So eyes open spontaneously, oriented normal conversation, and able to obey motor commands. Usually impact would be to verbal early on, so confusion or disorientation. If there's a brief loss of consciousness, then you would see that in terms of eyes closed and lack of ability to respond. But again, this is scored after a person is restored to consciousness in those short cases. Now, there are instances, of course, where people have an extended coma, but that would be clearly a much more severe injury. The Glasgow Coma Scale is utilized as one possible determinant of level of injury. On that scale, a score of 3 to 8 is indicative of a severe brain injury. 9 to 12 moderate, and 13 to 15 is mild, and that's also synonymous with the term concussion. You'll notice on this level of injury column on the far left-hand side, mild makes up the massive number of brain injuries that occur in this country every year. Mild is disproportionately the largest category when it comes to brain injury. Now, at QLI, the cases that we tend to see, because of just the nature of our population and being a post-hospital inpatient setting, means that when people are referred to us, they are generally going to be on the far end of the severe category from the standpoint of TBI. It would be very unusual and very rare that we would see someone in an inpatient setting for a mild injury. So when we are talking about our TBI cases, we have a very kind of skewed view of what TBI is. For the majority of individuals, if you look just at the diagnosis of traumatic brain injury, it is predominantly going to be mild injuries and concussions from which you would anticipate relatively quick recovery. Because they're mild injuries as well, these are considered to be grossly underreported. We have, a lot of data on brain injury in this country, but it's only if someone goes to a medical center or goes to a physician that this information shows up in the CDC's data. So if there's no medical attention sought, and a lot of people at one time in their life have had a mild concussion or even a brief loss of consciousness concussion that they didn't go to the doctor for, didn't go to the ER for. So those don't show up in the data. And a lot of that happens in childhood as well. My own personal experiences, I've had a few concussions as a teenager, riding a motorcycle and seeing how many steps you can jump down, things like that. Those don't necessarily get reported to your parents immediately, especially if it involves riding your motorcycle, because you know that means you're not going to be able to ride for a little while. So you don't report those kind of injuries. But so there are a lot of things that don't get into the record. But it just shows that even though mild is the largest category, there's even as many of those, if not more, that may be mild injuries that never show up within the data. A couple of things that you're also looking at here, if there's a loss of consciousness, you can see relatively brief loss of consciousness beyond 30 minutes. You've passed the criteria for mild injury. You're now into the moderate to severe range. And it's really a blunt measure as well. 30 minutes or less, more than 30 minutes and less than a day, are over 24 hours for severe with that loss of consciousness. AOC is alteration of consciousness, and PTA is post-traumatic amnesia. Both of those things are potential measures to look at severity as well. That post-traumatic amnesia is sometimes referred to now as post-confusional state as well. It's neurological disruption of cognition. This data was reported a few years back by the Department of Defense, and it was close to 400,000 military personnel that sustained brain injury between 2000 and 2018. A breakdown that's somewhat comparable to what you see in the data in civilian populations. You see the vast majority are mild in nature. So we're talking about a large number of individuals who sustain a brain injury, the vast majority of which are classified as mild in nature. And the terms mild, TBI, and concussion are fairly synonymous. The differentiation in what do you call a mild TBI and what do you call concussion comes really down to semantics. The term concussion is typically more associated with the impaired functional state that occurs as a result of an injury. And the term brain injury, in this case mild brain injury, is more associated with the pathophysiological impact or the biomechanical aspects of trauma to the brain. So it's really the same thing. It's just different terms referring to different aspects of that injury. Now, it's equally important to remember that although a mild brain injury rarely results in a life-threatening injury, the effects of that injury can be serious and can result, as I said before, in lifelong changes.
Well, and we're going to get into the definitions, and we're going to talk more about that. I think now is a good time also to talk about, maybe even why we built this presentation. I think there's a couple reasons. One, we historically have gotten referrals like this for our inpatient program, and we've had to figure out what's the best way to manage them.
Mm-hmm.
And we've even shifted and developed programs to do that. The other thing that we are seeing is a lot of our partners, especially on the work comp side, their ability to manage these has been it varies across the board. Anywhere from they don't have a way to find them within their system, right? They don't, it doesn't register for whatever reason.
How do you identify?
Yep, in terms of identifying them. And then even when they are identified, it's what are the risk factors for a normal recovery, which we're going to talk about, and how does that play out long term, and how do you really just get good outcomes. And so, the fact that many of them go unreported, the fact that most of these brain injuries are mild in nature, right? This impacts a lot of the decision making and the outcomes, which we're going to talk a little bit more about.
And what confounds as much as anything is even though the vast majority of mild injuries recover relatively quickly without substantial treatment, that means that there's a small percentage of them that don't. And so being able to differentiate those is something we're going to talk about.
Well, and the goal is to recognize them early so that we can,
the quicker you can identify them, the quicker you can effectively treat them, the better outcomes you tend to have.
Yep.
So a concussion is a mild TBI, and this is the somewhat informal definition that was broad and non-specific in nature, that it was a bump or a jolt to the head that disrupted neurotypical functioning. Now, this definition was from 1993, and it was a consensus statement that provided a greater degree of detail. And you see down there on number 4, again, back to that graph we had a minute ago, any loss of consciousness of more than 30 minutes would be considered outside the realm of a mild injury or concussion. But typically with a concussion, you're going to have that high level of Glasgow Coma Scale, maybe verbalization being the one that takes the biggest hit early on, and post-traumatic amnesia, or the difficulty encoding new memories for not less than 24 hours. Now, there is a more complicated, ACRM came up with a more detailed definition of concussion in 2022, and that was revealed at the conference a couple of Novembers ago. And this is the flow chart that looks at that diagnosis. Now, I wanted to put the whole chart up here to give you an idea of the progress made in detailing exactly what makes an injury a concussion or a mild TBI. The first one that you see there, which is a mechanism of injury, a biomechanical plausible mechanism of injury, that has to be present. And if you look down the flow chart, go to the left arrow, the solid arrow, criteria 2, clinical signs that a person demonstrates. Follow the flow chart down, criterion 6, not better explained by some confounding factor, then boom, that's all you need, 1 and 2. If you don't have number 2, if you have 1, you can use criteria 3 or 4, and we'll talk about those in a little bit more detail. So again, the first criteria is there must be a biomechanically plausible mechanism of injury. That can be a fall, a rapid deceleration injury, a blow to the head, striking the head against an object, or an object striking the head. The situation that you probably are presented more with the visual evidence of a biomechanical, plausible mechanism of injury would be watching just about any college or professional football game. At some point, somebody's going to have a collision that results in them lying on the field for a little while or getting up and staggering. That number one would be a biomechanically plausible mechanism of injury. Two large people running into each other at high speed. Somebody walks by your desk, taps you on the head with their finger and moves on. If you fall on the floor screaming, claiming that you've had a concussion, that is not a plausible mechanism of injury. So first and foremost, you have to have that mechanism of injury. Number two, and the example that I just mentioned of the football player on the field, that would be the subject displaying a clinical sign. A loss of consciousness is a clinical sign. Observed motor incoordination is a observable clinical sign. So if you have number one and number two, then you have a diagnosis of mild traumatic brain injury. Number three, these are 3 and 4 and are criteria, meaning they can be present along with positive findings for 1 and 2, or as long as you have number one, you can also use 3 or 4 to diagnose as well. The third criteria was at least 2, and that's acute within 72 hours after injury symptoms of alteration of mental status. Physiological symptoms like headache, nausea, dizziness, balance, vision sensitivity are reports of cognitive issues. Feel like I'm in a fog, I can't concentrate, I have trouble remembering things. Number 4 would be at least one associated clinical or lab finding. So this would be if I give a neuropsychological examination to somebody and they score poorly on some of the cognitive tests, that would be an objective measure of being able to look at their ability on that impairment or ability on that cognitive test. Physiological testing, balance impairment on acute exam, oculomotor impairment. So symptoms provocated in response to vestibular ocular challenge, follow my finger with your eye, or I'm going to hold my finger steady and I want you to look at my fingertip while you move your nose to the left and the right. Looking at those saccades and being able to see that that's not a normal response after injury. And a new one that we have really not had up until the last couple of decades, and that is elevated blood biomarkers indicative of an intracranial injury. Now, a lot of the early biomarkers really were things like tau released into the cerebral spinal fluid, which can then be picked up within the bloodstream. But elevated tau within the brain is also associated with a lot of neurodegenerative conditions, and so it's not exclusive to brain injury. But there are a few blood biomarkers that within the last decade have been identified that are exclusive to brain injury and therefore can demonstrate both the presence of and the severity of an injury in that case. Neuroimaging evidence of TBI is rare, but possible. So the image on the left, you can see evidence of focal brain lesioning in a case that otherwise met criteria for mild TBI. In other words, from the standpoint of Glasgow Coma Scale, post-traumatic amnesia, alteration of consciousness, all of those were within the mild category. However, some lesioning exclusive to that injury were present in that case. The image on the right is really from a study looking at abnormal white matter changes in chronic mild traumatic brain injury, something that is called chronic traumatic encephalopathy, or CTE, something that we have heard a lot about, particularly in professional and college football, professional football in particular, over the last several years. Symptoms that are common to concussion or mild traumatic brain injury, headache is probably one of the main ones, and that's a really interesting symptom with regard to brain injury. You would probably naturally think that headaches are going to be more common the more severe a brain injury is, and that's actually not the case. Headaches are much, much more common in mild injury than they are in moderate to severe injury. And I still have yet to see a study that really can definitively explain why that is. There are some hypotheses around the possibility of a compromise of the sensory symptoms necessary to even be aware of and perceive headache. But headache is an interesting aspect of the brain's function and one that is difficult, certainly at times, to pin down. Now, post-concussive syndrome, also known as post-concussive symptoms, again, most of these will occur within the first week to 10 days and then gradually reduce in severity until they resolve, generally at or before 3 months. That's the case for the vast majority of individuals, but again, not all. For the remaining minority of cases, persistent symptoms can go beyond that 90-day expectation of recovery and may persist for months or years. Now, this, like Steve, you mentioned a minute ago, this really underscores the importance of early identification of those individuals that are more likely to develop an unfavorable outcome, that have poor outcome or symptoms that persist, and to provide interventions that have been shown to be effective within that early stage. So that is very important. There are a number of factors that have the potential to impact outcome following concussion, or factors that are associated with a higher likelihood of favorable or unfavorable outcome following concussion. A literature review that was conducted by the World Health Organization in 2004 identified factors predicting the development of post-concussive symptoms into three primary categories: demographic, the person, those that are listed there; the nature of the injury, with motor vehicle collisions being most highly associated; and then the consequences, again, the Glasgow Coma Scale, whether or not there was a loss of consciousness, post-traumatic amnesia, all those factors were associated within that early on. Now, there was a study that was done much more recently. This was done in 2017, and they looked at all of these different potential prognostic factors. So these are a bunch of neuropsych tests, a bunch of different scales, subjective report scales, pain scales, quality of life, and patient complaints on a post-concussive symptom questionnaire. And not listed here, but they also had access to previously reported MRI data on their subjects. From all this data, the researchers built a model that best predicted in the early stage after injury patients that were most at risk of developing post-concussive syndrome. And it actually had, the model that they came up with, had better than 95% sensitivity and just over 77% specificity. So the ability to identify that likelihood was present and to rule out those subjects that don't have those indicators. From all that data, the authors concluded that there are complex relationships that exist between all those different measures, but it underscored the importance of mood and subjective complaints. That was one of the biggest discriminating factors. They extracted initially 5 domains that, doing factor analytic studies on it, ended up with 3 that really resulted in that 95% or better ability to classify those. Complaints being first, quality of life and neuropsychological test performance falling last. As a neuropsychologist, I feel a little bit bad that we come in last place on this, but it just kind of shows that these objective tests are less useful than subjective measures when it comes to identifying these patients. For complaints, the number of complaints really established a cutoff score. It really didn't matter which of those complaints they had. It's just if they had 4 or more, then they fell into the category of those that were likely to develop post-concussive symptoms outside of the typical recovery range. For quality of life, the scores were weighted, so it depended on the items that were reported and a calculation based on those weighted scores. But generally, people scored about twice as high on that fell into that category of falling into an unfavorable outcome. And then with regard to neuropsychological assessments, most of the tasks weren't discriminative, like I said, in predicting favorability of outcome, but there were a couple. I think trail making test part A, which is just a sequencing of numbers, fill in the, connect the dots. The Stroop color test, which is how rapidly you can name a bunch of color patches. And then the Stroop word test, which is simply reading the words of those colors quickly. So those are, as much as anything, kind of pure measures of processing speed. So from a neuropsychological standpoint, that would be what you would be measuring in that particular case. So just to quickly recap, there were factors identified in early detection that were most associated with the development of post-concussive syndrome and atypical recovery following concussion. And that's the list that you see right there.
Yeah, and I think, really the reason we did the summary is the practical application of this is, whoever is recognizing that there's a concussion in place or whoever's reporting it, we would hope that at the very least we're starting to ask a few questions like this, right?
Yep.
Or asking a provider to assess these sorts of things so that then we can gather that data, and it's going to start to give us some information on the prognosis.
Yeah, ideally, we would all have that model in mind when we do that, but as long as you kind of know these are the things that are most discriminative, if those are the things that you're paying attention to, you're going to have more success in identifying those folks early on.
Mhm. Real quick, one thing. We do have a question around post-concussive symptoms, the subjective nature and treatment. We're going to get to treatment. If we don't answer that question, just ping us back and ask for more clarification or hit us up after. All right, Jeff.
That is actually yours.
Oh, this is mine.
Yes. Hand off.
Okay, so we talked a little bit about prognosis. We've also started to bleed into assessment as well, right? And so you've listed a lot of what we would consider objective assessments. There's a whole host of them that can be used. Depending on the provider, they're going to have their favorite ones. But this is related to another study back in 2020 from the American Journal of Sports Medicine, where it took a look at the use of the post-concussion symptom scale. And so there were 4 symptom factors that they took a look at: the cognitive, migraine, and fatigue factor. They called it CMF. A person's affect, their sleep and arousal cycles, as well as the somatic symptoms that they might be experiencing. So the reason we highlighted this was that the prognosis and looking ahead at their recovery was different dependent on the time frame, right? So within 1 week, the CMF factor, what they found was the most robust predictor of a prolonged recovery. So if that was really present within 1 week of the injury, it was pretty predictive that that recovery might be a bit challenging. Alternatively, within the next 2 to 3 weeks, the affective factor was the most robust predictor. So things like how they're feeling around their emotions and the social emotional factors that they were including. So we just thought, to highlight, make sure that you're looking at this as a continuum, not just a snapshot in time, because it can change depending on where the person's at in their recovery.
And it's complicated by the fact that oftentimes affective disruption may have existed prior to that
Yep.
injury. It's the exacerbation of that and the severity of that exacerbation that you're looking at.
Exactly. All right, same thing, just to highlight, here's the main measures that they used. These are pretty traditional when we get someone with a concussion in our telerehab outpatient program. We pretty much do all of these. The sleep assessment was more general in nature, but I think the point here is do something to assess someone's sleep, their sleep hygiene, pre or post injury, as well as their quality of sleep. Because as we all know, sleep is a huge factor in recovery. The neuropsych cognitive testing, same thing. Jeff has already alluded to this. Neuropsych testing has its place, but it isn't necessarily the first go-to. And honestly, we'll talk a little bit later too, is it's kind of challenging to find a neuropsych, get someone in a timely fashion. And so it may or may not even be an option in some cases.
When you're talking about trying to identify something within a couple of weeks and you're talking about a service, it typically gets 6 to 9 months to get it arranged.
Yeah.
Probably not going to be helpful.
Yeah. And so it ends up becoming like, what do you do instead? Or to buy yourself some time if you do need that down the road. And so these are some of the ways to do it. There's also really some just observational functional ways to see how someone's doing that are really accurate, actually. One thing also to mention, considering the Buffalo concussion treadmill test, this is pretty much a gold standard out there in terms of assessing someone's tolerance of physical activity. And so what this does is it considers someone's heart rate and compares it to when they start to experience symptom exacerbation.
Volume up.
Jeff, I'm gonna have you tackle that. I'll keep going. So what they're starting to look at is there's a very methodical way to do that. Wow, this really challenges our presentation skills when we have
That
technical
segue brought to you
difficulties.
by Don Terry.
All right, reset. Okay, so just again to highlight, the Buffalo treadmill test is taking a look at the physical aspects of someone's symptoms and when they are exacerbated by physical activity. So primarily looking at heart rate as well as symptom exacerbation, but it also establishes a really safe protocol for exercise prescription. So it also assists with differential diagnosis. So you can see there's the physiological post-PCD, there's vestibulocular PCD, and cervicogenic. What this test is going to do is going to confirm or disconfirm physiological post-concussive disorder. So if with increased physical activity and heart rate, you get a symptom exacerbation, you can acknowledge the fact that it's a physiological post-concussive disorder. However, if you don't get that, you should start to look at vestibulo-ocular symptoms. So Jeff mentioned the idea that when we move our head and our ability to fix our eyes on a stable object or vice versa, you might start to look at some of that, as well as cervicogenic when there's more musculoskeletal and cervical type disorders that are associated with this type of injury. It also identifies some physiological variables associated with these symptoms, which goes back to that physiological differential diagnosis. Are we good on sound here, as far as we know?
Sound great. Man.
Okay. Sorry to those who are having sound issues. We did our best to do this on the fly. So, all right. Now, in terms of decision making, with this group, we identified the topic of return to learn or return to work. There's also return to sport. So we're going to specifically talk today about returning to learn, primarily return to work, just given our audience, but just know that there's information out there across the board. It's not all that different, but there are some differences related to return to learn, work, and sport. So the consensus along these lines is that cognitive rest is really important right out of the gate, especially an interdisciplinary team approach to the question around something where an injury is multiple years or months down the road. An interdisciplinary team approach is going to be even more important down the road, but we actually recommend some level of interdisciplinary approach early on if possible, making sure that we're monitoring progress and talking about the levels of support along the way. So first and foremost, it's important to know that the return to the workplace is different than returning to work. This is a really key differentiation. Same thing in terms of school, right? Returning to school is different than returning to learn, right? So when we talk about returning to the workplace or to school, it's the process of actually going back into the physical environment, which we recommend you can do that as soon as possible, right? As soon as that person can tolerate, get them back into the environment. However, the process of returning to learn or work should be individualized to the person in terms of productivity, full participation in those job-related duties, things like that. So, we recommend considering physical and cognitive rest. The timing and amount is going to vary depending on the person. The gradual return to social and cognitive activity over the first 4 weeks. Again, if we're looking at a normal recovery, only 10 to 15% of these individuals are going to have ongoing struggles with the return to learn, work, or sport. But we want to make sure that they do have a gradual return to these types of activities. And then back to, returning to the workplace or work, even though the symptoms may not be 100% resolved, they should be able or are likely able to participate in some of these activities at a scaled back capacity, and then gradually scaling them up as they start to improve.
Yeah, and that scaling up is really dependent upon the reoccurrence of those symptoms as you increase demands, because the recovery is supposed to be a process of increasing demands over time up to the point where the symptoms start to reemerge and then backing off a little bit and then challenging it again.
Yeah. And we get a lot of folks coming to our clinic where they've had a physician that's just like, go home, lay down, rest 100%, which there's a time and a place for that, but it's typically really early on after their injury and very quickly.
Typically really brief.
And very brief, right? Very quickly, we should be moving into some level of activity.
You can develop a negative routine as well.
Absolutely.
Can further exacerbate the problem.
Absolutely.
I have a question about cognitive rest. Could you expand upon that a little bit, what that actually means?
Yeah, I mean, I think it's really anything related to someone's need to attend to tolerate, whether it be problem solving or the demands of their job.
Yeah. With work, it's the cognitive demands of your job. With students, it's the learning process. Or video gaming can be a piece of that as well. Anything that requires a lot of attention, a lot of cognitive reaction. That's something that you want to ease up on to begin
Mhm.
with, if that's a problem.
Yeah, I mean, we see this on both sides. We see folks who just like shut it down completely, which we've already talked about isn't a great idea. But we've also dealt with people that the demands of their job don't allow them to gradually return, right? And so it's not even, some of it's the physical nature of, can they be up on their feet, sitting, and have the physical demands of their job that they can tolerate, but really the pace of their job and the duration at which they need to pay attention and interact and concentrate on whatever it is they're doing. Sometimes it's just way too fast
Yeah.
and way too
The
demanding.
merge onto the interstate versus driving on the back road.
Yeah. So when we talk about cognitive rest, it's really anything that is demanding in terms of those cognitive functions, and it's probably job dependent. It's dependent on the skill level as far as what they're doing. Screen time, no screen time, like there's a lot of factors, but that's why we go back to, we have to have a good inventory of what it is the demands of their life are. And then how do you start to make some decisions around what's too much or what's too little, and how do you start to methodically add some things back in. So I wish we could give you a cookie cutter way to do that. We're going to talk a little bit about some options for return to work, but well, I guess we can do that now while we're into it. So, some options for return to work. Could they return to their job remotely, right? Don't even go into the workplace, but start to take on some duties working from home, or go back for a couple hours at a time each day, and then slowly go from part-time to full-time. So a gradual increase in the demands, whether it be physical or cognitive, are a few ways to do that. We recommend going even into something that's light duty. Maybe it's not their job that they used to go back to, or that they used to be doing, but there's an alternative job that they could do 8 hours a day that's more light duty, more administrative in nature if it's a more physical related job. So there's lots of ways to slice it. We just recommend, taking a really individualized look at it. And this kind of gets us into the next component where there's a lot of folks that should be involved. Obviously, the injured worker, whoever their support system is, be it family, friends, coworkers, hopefully, their employer needs to be involved. So as we're making decisions about around what's possible for return to work, if the employer is not bought in, that's going to be problematic. If they don't have light duty jobs, that's problematic. So obviously, if there's not a level of collaboration in that regard, there's going to be a disconnect in terms of bringing the person back in an appropriate speed. And then the medical team, as I've mentioned, really early on, oftentimes what we see is a physician is involved and a physical therapist is involved. Those are usually the two key people. And most of the time, it's probably fine. But when you're starting to see some vision deficits, when you're starting to see some cognitive deficits around memory, organization, and problem solving, things like that, or those social emotional factors, those other three disciplines at the bottom there become pretty important. And oftentimes it could just be a consultation. We're not necessarily recommending full treatment, especially early on, but making sure that we have good tabs on it. But back to the other question around further on down the road, we have found an interdisciplinary approach is the most effective. And we typically recommend assessments with all of these disciplines, PTOT, speech and psychology. And then from there, we can start to piece together which disciplines are front and center, which disciplines are a little bit more supportive, so that we can take and look at the person's life holistically in nature, and then flex the treatment to match that.
Got a question regarding a local concussion clinic tells their patients to resume normal activities to retrain the brain and does not recommend brain or cognitive rest. This provider states that new information does not support that. Is that a conflict within the what's new and what's tried and true?
Well, I think you're seeing right here on the screen a study from 2019 that looked at early intervention in this, and it involved a more gradual process. The Buffalo Protocol, from a physiological standpoint that Steve will be talking about, also involves physiological demand being increased over time. The state of the art right now when it comes to concussion recovery is the period of rest that is necessary initially physiologically to return to some degree of baseline with whatever symptoms exist, and then gradually increasing the demands both from a physical and a cognitive and emotional standpoint back toward their eventual complete baseline.
So not a predicted time frame other than what's prescribed for the
No,
individual?
again, when it comes to the brain, if you try to apply a single metric and a single outcome expectation, you are going to fail for the vast majority of cases because they are all over the board when it comes to what their recovery needs are. It is highly, highly individualized.
Well, back to a previous slide, we had progress monitoring on there, right? We recommend very frequent progress monitoring because there might be a day I see someone in the clinic and we make a decision to ramp things up physically or cognitively for the number of hours of work or, you know, even on the treadmill test, and then we get a negative response. Sometimes there's a little bit of guessing that goes on in terms of like, oh, I think this person can tolerate this increase, and maybe they don't for whatever reason, or maybe it's enough that creates a little bit of exacerbation, but they need that kind of out of the comfort zone approach to push them through to the next level. So there's this give and take a lot. And so if you're not monitoring progress very, very regularly and getting feedback from the individual, the workplace, or whoever's around them to say, hey, here's what's going on, it makes it really hard to make decisions because you don't have the data, you don't have a real-time gauge of what's going on. So, I mean, I guess to reiterate that part, it does help with decision making when you have lots of touch points, whether it be from the same provider, multiple days, or at least every week, or multiple providers, right? So an interdisciplinary approach allows, you know, let's say Jeff and I are both working with someone. I see him on Monday, and Jeff maybe sees him on Thursday. As long as Jeff and I are speaking, maybe we can get another touch point in there and we make some different decisions along the way. And we can adjust as needed very, very quickly rather than having to go a full week or two between treatment sessions or whatever the case may be.
Well, just kind of like we said early on, brain injury is not a homogeneous diagnosis. Concussion is not a homogeneous diagnosis. Therefore, it is not going to be appropriately treated with a homogeneous approach. You're going to have to individualize. The same lab that involved in that prognosis data I talked about earlier developed and evaluated the effectiveness of an early intervention program aimed at providing education and cognitive rehabilitation to patients who were determined to be at risk for developing post-concussive symptoms. So what they did was they took all of the individuals that were diagnosed as likely to develop poor outcome and then split them into an experimental group and a control group. So this was a randomized controlled study. The experimental group received very specific intervention in terms of education provided in the number of educational sessions, as well as at-home computer-based cognitive exercises, whereas the control group received more typical care. They were seen at 1, 3, and 6 months post-injury. They received information on the natural history and evolution of mild TBI, pain management if necessary, and then referral for appropriate outpatient services. Next slide. Now, the experimental group which received the intervention had a total of 14 scheduled sessions, beginning 1 month following injury and finishing at 6 months. They were scheduled for every other week for the first 2 months, and then about every 2 weeks for the remainder of the sessions. The psychoeducation included the recovery process after injury, the range of typical sequelae and anticipated symptoms, and management of those symptoms. Information on pain management, information on mood disorders, so very specific to the type of issues that each patient presented with. And then also, like I said, went through a process of some computer-based programming that was progressively more difficult exercises that followed the same order of sessions for each participant, but it also was tied to the progress of each participant. So the amount of time that you spent on a particular level of difficulty varied by patient depending upon their abilities. So patients were able to progress levels by making no more than 3 mistakes at a given level. Otherwise, they would repeat that level until they met that criteria. Very similar to most of the concussion recovery.
Which still goes back
protocols.
to like patient A, B, and C might have a
Exactly.
different treatment protocol based on how they respond.
Yeah,
right.
Same process, but varied in terms of time for each patient. And they were visual and auditory in nature. Now, the ultimate findings that they had from this was really some fantastic numbers that you normally don't see with some of these more complicated cases. So they were no longer meeting the criteria for post-concussive symptoms for 94% of the experimental group at 6 months, as compared with 48% in the control group. So that is a dramatic difference Again, this is a pretty intensive program. You're talking about 14 sessions that you are monitoring. It is probably the gold standard at the moment for the cognitive aspects of recovery. And Steve, you're going to address some of the physical.
Well, and I think if I remember this, or even in some of your notes, this was within the first 6 months of someone's injury, right?
Yes.
This was assuming that you were really aggressive early on and
started providing this intervention at a month post-injury.
Right,
Yep,
which
so early on.
You know,
that means they had to be identified within the first few weeks.
Yeah, so it requires early identification and then early utilization of the right providers who are going to do this care.
Yep. Now, again, looking at the 6-month return to work in this particular population, 85% of those in the control group had resumed work at the 6-month mark, with 80% of them going back at their prior level of work. That just shows, again, with mild injuries, most people are going to recover. These were folks who did not have that intensive rehab program. However, for the experimental group that did get that early intervention and intensive intervention over time, 100% of that group went back to work in 6 months and 93% returned at their prior level of work. So there was a difference there that can be quantified. The bottom line was the intervention program was very effective in modifying those predicted outcomes of patients who met the parameters for early identification for risk of post-concussive symptoms. Now, again, I don't think that every provider is going to be able to provide that high level of intervention early on, but if you're asking the right questions and trying to put some things in place, you're likely to have a positive impact.
Well, and just early education, right? If you're just educating on someone, what is concussion?
What is the typical
What is post-concussion?
outcome?
What's the typical outcome?
The fact that you have symptoms right now would be predicted on the basis of the injury that you've had, but the second half of that coin is we also anticipate that these would resolve relatively quickly. And there are some things that you can do that will actually help that process.
Right. Okay. So, another study also looked at the efficacy of remotely delivered intervention. So, there's really two ways to look at this from an outpatient treatment perspective. One is the more traditional approach where someone goes to a brick and mortar clinic that may or may not have an interdisciplinary opportunity, right? So more than just a physical therapist or an OT or, physician involvement, things like that. Admittedly, we take a more non-traditional approach. We utilize our telerehab services to provide really all these interventions the majority of the time, right? There are times where we refer out to an in-person clinic or have someone to come to our clinic, but really those are the two different approaches that you could take. This particular study looked at the use of a remotely delivered intervention, and it was a randomized controlled trial design. So here's a quick look at what the person got. So post-injury, they received a short phone call. The first session was up to about 30 minutes. It was simply done by phone. And then you can see there the consistency around early learning around concussion. So this particular study used e-learning videos that could be done by the person on their own time, 5 to 10 minutes each, with about 50 minutes in total of time commitment. And then from there, there were sessions that followed up that in this case did not exceed about 3 hours in total. And so these were done through video call or virtual call. And so that totaled about 8 weeks in nature. And so with that initial remote interview, the intent was relationship building, the ability to identify the challenges and or risk factors, many of which we've talked about up to this point, and introduced the learning videos. The learning videos, you can see there what was involved in those, but it was really around the difference between concussion and PCS, management of PCS, the impact of stress, and what it, how it affects a concussion, and then introduction to goal setting and those remote follow-up sessions that were yet to come. And then, in terms of the remote counseling, making sure that the goals were clearly identified. I think this is a huge piece that cannot be missed, right? Understanding someone's goals around returning to work. If someone's saying to me like, yeah, I might go back to work, or I don't think work is in the cards here for another several months, that's going to start to trigger me as a provider. Okay, where's this person at emotionally or in terms of their motivation to return to their previous level of activity? Again, bumping it up to what were you doing initially before your injury, and then how are we starting to build out that gradual return to work, play, sport, that sort of thing. And then providing them some guidance around some decision making related to that, right? So what does it look like with your employer to go back to part-time work, and what are the duties that you're going to be doing, and making sure that we're helping them manage and prioritize their energy. And then use of CBT. The psychological component of this is huge, so that we're helping people really buy in and take accountability for what it is they're feeling and what it is they want to get back to. So CBT is I believe, not an unfamiliar topic within this group. All right, we talked a little bit about the progress monitoring, just making sure, at the very least, weekly monitoring could be done more frequently if you have a way to do it. But making sure that you're taking a look at the physical, cognitive, social, emotional, right? How are you doing related to if it's emotion, anxiety, depression, things like that. And then how's it going at work? One other quick note on this: if someone goes back to a different job or a scaled back job, making sure that expectations are really, really clear. How is performance being evaluated by the employer, right? And so we want to make sure we get feedback on that so that the person is performing at an appropriate level. And if they're not, it also can lead to some different discussions. This is just a slide that highlights much of what we talked about in terms of return to work. So I'm not going to spend a ton of time here. Here's some other considerations.
And these slides will be available.
Yeah, these are all available. So just in the essence of time, back to the Buffalo concussion treadmill test. Here's a little bit more information on what you might be looking for. I think we had a specific question on heart rate monitoring and things like that. If we have time, we'll try to get to that too. One concept, this probably isn't unfamiliar either. We use this in quite a few of our presentations, but making sure that if the person is struggling, we may want to consider an increase in therapeutic intensity, or you could also insert just general support for that person. So, if they're going through a harder time, we may want to bump up the touch points. We may want to consider additional days or amount of time in formal therapy, or maybe their support system is a bit more present. But when things are going well, we can make sure that we're monitoring their progress, but we can probably back things off and allow that to match their overall performance within their life. And that could be, again, cognitive, physical, social, emotional. When we talk about, what do we do to help someone, I really think it comes down to that therapeutic intensity and structure and support. So if I'm taking a look at all of those factors around that initial or that middle square there, I'm taking them into account, starting to weigh them out and prioritize them, and then making my decisions around therapy, what disciplines need to be involved, how are we making decisions about level of activity, pacing, things like that. So just making sure, back to a lot of what we talked about, there isn't really a cookie cutter blueprint for this, but we are trying to give you at least some mental models to start making some decisions, consider all those factors, and then, go from there. In terms of rehab, at any point in time, we're going to be looking at a pretty long list of things that could be present. This isn't necessarily with a concussion or mild TBI. They are all there. These are a lot of the regular ones that we see. And so making sure that we go back to having providers that can navigate these appropriately. Just to quickly highlight telerehab. The reason we use telerehab, the reason we've seen it work, is because we don't have to take the person out of the environment that they're in. And then even when we do take them out of the environment, such as going to a clinic, what we also know is that what we see in clinic is probably different than what is going on at home, or there's some things that can be missed. And so telerehab allows us to see it with our own eyes, potentially see them at work, potentially see them in other situations that are challenging, so that we can provide feedback, provide insight, provide support around strategies to change the behavior or get progress.
Well, and telerehab also allows you to bring the expertise that you need for these types of cases into places where that just may not exist locally.
Yeah, good point. So, a local clinic may have those providers present that we've already talked about, but a lot of times they aren't talking. They're not collaborating back and forth. They're not, reinforcing different concepts from session to session between disciplines. And so for us, we do that. We also have some behind the scenes structure in place where we are, so call it, rounding on each person and making sure that we have a good plan moving forward so that the right hand knows what the left hand is doing. And that's a huge piece in terms of getting good results and doing it efficiently. So we're looking at formal and functional aspects of their day. So that formal being those objective measures, what do we see in formal therapy? And then what are we seeing as they go throughout their day? And making sure we have a level of oversight, a practical therapy duration and frequency, and as we've mentioned, clear and measurable goals. So this is just our approach. It's not necessarily the only way to do it, but this is our take. Anything else to add?
Got a couple of questions coming in.
Yeah, I have quite a few questions. So we're going to try to get to questions. While we get some questions, I'm going to put up the poll question. This is the one and only poll question, so please answer this. And this is one way to get your CEUs. Launching that now.
Okay, Don.
Is there any way to tell the difference between a fraudulent TBI and testing the way, excuse me, those can be determined whether they're true TBIs or someone might be gaming the system?
Well, from a TBI standpoint, the biomarkers, the physiological evidence, I mean, a lot of this is somewhat, either observable by an expert in the moment if it's a situation where that's available. And I'm thinking now of, sporting events where you've got typically, team side doc that's observing this and can see that. From the standpoint of objective measures, as a neuropsychologist, there are some validity measures that can be administered in the course of an evaluation, some that are embedded within the typical measures that we use. That is one way to determine if cognitive and self-report symptoms are legitimate. From the standpoint of self-report surveys, there are surveys that are designed to tease out whether or not someone is being consistent within their responses or exaggerating their responses. So that is a possibility as well. I think the other one that you may be familiar with often is observations that are in direct contrast to the reported symptoms. In other words, an individual who says they are unable to lift 5 pounds and then may be observed doing something that they say they can't do. We've seen that at times with individuals that we've done evaluations with who claim physical abilities that are inconsistent. And physicians actually have a way as well in looking at physical functioning to determine whether or not the individual is putting forth legitimate effort. I think Nathan Zasler, if I'm not mistaken, Dr. Zasler has done a lot of work in that area and on a lot of documentation. I've seen a couple of his presentations on that for neurologists and being able to determine the legitimacy of symptoms. And then the other would be just, observation. Sometimes, particularly insurance cases where there's a, particularly egregious claims that clearly don't match what the person is observed doing because they filmed them walking through Lowe's carrying, 2x4s over their shoulder when they come to the office with a walker and can't move. So anything, that there's a lot of different ways of doing that, but some of them are a lot more involved, and you're probably not going to enact unless there's a substantial issue on.
Yeah, the only other thing I would add is like the further down the road, you get these folks who have had these issues for, months to years. And I think one of the things that we do as a provider is we just acknowledge that it's real to them.
Yes.
Right. And whether it's, exactly what's, whether or not they're putting forth full effort or not, right out of the gate, we just assume that they're putting forth full effort because what we found is most people are. The majority are wanting to get better. They have some bad patterns, but that doesn't mean all.
Yeah. And if you get cases that fall into that functional neurological disorder category that everybody absolutely is terrified of, you also treat those in the same way that you treat the other symptoms.
Yeah, I mean, we're looking at the physical components, but the further down the road, you better be looking at, are they educated on what their injury is? Yeah. And then do they understand the social and emotional factors that contribute to their injury, right? And how are they responding to that? And it becomes less about the physical and physiological issues and more about how am I just like viewing my world and viewing recovery and potentially managing some of these symptoms that I've been dealing with for a long time.
Yep.
Would you address Botox and post-concussion symptoms?
I mean, I think Botox is just another tool in the tool belt, right? So, I've seen it used for headaches. I've seen it used for just muscle relaxation and things like that. So if it's being recommended, I would want to have a good reason why. What are we getting with it? Back to symptom, just observation, right? If you get it and the symptoms improve, great, could be a nice tool. If you get it and you don't see a change, I would probably say, okay, we gave it a shot and move on to something else. So it's just more of a tool in the tool belt.
Yeah, with headaches, if it looks more cervicogenic in nature,
Yeah,
that
cervicogenic would be
likely,
definitely.
yes, be a potential indication.
Yep.
We've had a individual that's had a client with snowy vision after a car accident. After 3 years, it's not resolved. Is this rare, or do you have any feedback about the snowy vision?
Well, number one, I would say, yeah, that sounds like it would probably be pretty rare when it comes to vision after concussion. Oftentimes, light sensitivity is the biggest thing that you see. To me, this sounds more like some type of retinal / vitreous issue that, floaters that you have in your eye. Again, working with a good, ophthalmologist with that, neuro-ophthalmologist in that particular case. Yep.
If you don't see the poll question, when you exit the webinar, you will get a notification of a survey. Fill out that survey and you'll still get your CEU. Biomarkers. If biomarkers were complete at the time of injury, would the provider order follow-up biomarker testing post-concussion if they're still symptomatic?
Biomarkers are something that usually are pretty quick to respond and then fall off pretty rapidly as well. The one that I'm most familiar with is a calcium binding protein. I think it's S100B, if I'm not mistaken. Typically is present within the first hour after traumatic brain injury, and levels peak around 6 hours afterwards and then begin to fall off. So it's something that is very acute to injury in nature. So most biomarkers are really good early on for determining neurological insult. That may change with some other markers. Again, I'm outside of my depth when it comes to that, but yeah, it tends to be something that follow-up would probably not show you a whole bunch with the biomarkers that I'm familiar with.
We're at 10:01. I think we probably have time to stick around and keep answering questions. We just want to be mindful of everyone's time. So if you got to drop off, quick reminder, we will have a recording of this posted on our YouTube channel. So you can access this after the fact. You'll get your CEUs. Remember, as you log off, that should prompt you that. But if there's a few more questions, we can stick around and answer them. And if you all want to stick around and listen to us yammer.
And thank you very much for joining us today.
Thanks.
Thank you for joining us. This is our last webinar of the year. We will be taking December off. We've given our presenters a break. Thank you so much for your loyal attendance. I did some research, and we will have eclipsed 12,000 attendees since 2017 attending our webinars. So I thank you to the audience, and looking forward to 2025 and a bunch of great new content. Back to the questions. Amantadine has been prescribed for concussions to improve focus. What are your thoughts on this medication?
I am not a physician.
I'm like, I don't even have PhD behind my name. So Jeff, you're the closest we got to answering this one. I mean, we have talked, even part of this presentation, we know we don't have a medications slide on here. Medications have their place in terms of what medications are being used. Again, that's not our wheelhouse. I would say our stance on medications is use the ones that are needed and get rid of the ones that are not. And so we're gonna, if you're working with us, we're gonna make sure we do a good inventory of what medications are you on, making sure that they are as minimal as possible, understanding that they do have their place, but also understanding that typically down the road, it's not the medication that's gonna be the fix. It's going to be something else. And so we want to reinforce that mindset.
With the major disclaimer that I am not a physician, not a prescriber, and I'm way out of my depth to answer this question, I will still say what I know, which is, with severe TBI, often amantadine, bromocriptine are utilized to kind of wake the person up to get the neurons firing. I think in the vast majority of cases with concussion, that would probably not be a necessity. But to say that in most cases, that means that there are probably some for which that could be inappropriate. And again, not a physician. If that physician determines that that's an appropriate use of that medication, then yeah, that's what they would do.
Do you have any input regarding impact or iBox testing?
Impact is something that has been utilized particularly in
Sport.
Yeah, in sport and school. Impact testing is a good kind of brief assessment across the board of cognitive physiological symptoms. It is, I think, good in its place for being able to, in a brief, very brief period of time, screen for those symptoms. And it does give you the ability to identify kind of those early cases that you need, at least in a sporting environment, to prevent that second injury, potential second injury syndrome.
Mm-hmm.
We had an attendee that asked about heart monitors. You briefly addressed it, but is it useful?
I've got 2 on right now.
Yeah, I mean, I think
no, seriously, I've got an Apple Watch and I've got an Oura Ring, both of which give me heart
yeah,
rate,
it gives you data,
recovery data throughout. Yeah, I think the ability now of all of these consumer level products that give us all these physiological measures. I'm a data geek to begin with, so I love all this stuff. I want to see how many periods of REM sleep that I have last night.
Yeah,
this stuff gives us that.
And at the end of the day, it's you're looking at what was my heart rate and did I have symptoms, and are we starting to can we match that up and then start to raise heart rate with less symptoms? I mean, I think ultimately that's the decision making. And so the more data that
you have
baseline
heart rate data and somebody's complaining of pain, their heart rate's typically going to be up as well. So that gives you an observable measure that can be utilized to look at that. Yeah. Has its place. It's not going to be the be all end all, but it's nice to have an extra data point when you have it.
This will be another at your discretion. 1 year post high impact car accident with loss of consciousness. Is there an anticipated length of treatment? Just a ballpark.
Anticipated length of treatment for somebody who a year ago had loss of consciousness associated with car accident.
Yep.
Mm-hmm.
Length of time of that loss of consciousness, I assume, was less than 30 minutes.
Indeterminate by me.
Okay. Then the answer would be it depends. Need more data.
Need more data. Yep.
Yeah. Or the old 8-ball answer of unclear, ask again later. Please feel free to.
We do not have an 8-ball in here, but that's a good good utilization.
Shows how old I am as well, right? But feel free to send that question by way of email as well.
Yes.
It's probably good just to kind of wrap. We're getting lots of good questions. We will try to go through these with the disclaimer again, without lots of data or information. We're oftentimes guessing. We want to be as helpful as you can in terms of prognosis and what to do.
If the response is very broad and vague, it's because it's difficult to be specific.
One thing I will just throw out there is if you have a particular person who you're working with, one service that we do offer is just to give us a call. We might ask for a few medical records, and we're happy to review it and see if we can be helpful. So shameless marketing plug, but even if they're not appropriate for our program, we'll try to give you some recommendations on where to go. So for us, it's more about helping the person and helping you. And if they happen to be good for us too, then we can do our best to help there. So if you have a little bit more information, you want to send it our way, or at least hop on a call and kind of riff on it a little bit, we're happy to do that. So with that, we're going to wrap things up. Don, thanks again for the look ahead to next year. Jeff, thanks again for joining us. Appreciate that as always.